Okay, and we'll have Adam start us off.
Thanks, Vi. First, I just wanted to say thank you to everyone for attending and for taking some time to hear about our program, to learn a little bit more about long COVID rehab. Certainly, we've been working hard at Cornerstone to bring a little bit more and share a little bit more knowledge with the community about what we're doing with long COVID. So we really appreciate this opportunity. As Vi said, my name is Adam Brown. I'm a physiotherapist. I've been working on developing appropriate ways to approach post-viral illness and long COVID in particular since the beginning. Um, I'm also a clinical research coordinator with the University Health Network, which has allowed me to connect with physician scientists who have helped to guide and advise us on this program that has evolved over the last few years and continues to evolve as we learn more about this condition. So today, I'm going to go through a short deck. I do want to um, encourage, if you have a question about a subject, just to throw it in the chat, and Vi will happily interrupt me and ask your question. There will also be an opportunity at the end for you to ask questions. And if you know the content doesn't show up on a slide and you have a question, you can save it for then if you wish. So the first thing that I want to talk about is kind of our approach to assessment and treatment planning for long COVID. One of the things that sometimes isn't appreciated by the clinical environment, although most people who are living with long COVID have a good appreciation, um, is that long COVID is a big umbrella term, and under that, there are different syndromes. And any given patient will have different amounts of each syndrome. And there may be syndromes they don't have at all, and others that are very dominant in their condition. And so our assessment tries to capture which syndromes are particularly important for this individual in terms of limiting their function. And from there, what strategies should be employed and in what sequence. And so anybody any long COVID patient's journey looks a little bit different, and they can be vastly different, but each one is a little bit different. So we use at the outset a tool called the Yorkshire COVID-19 Rehab Screening Tool. And the reason we use that is that it's a fairly comprehensive tool that captures a wide variety of symptoms. We use an MCAS or mast cell activation syndrome screening tool. Um, we look at diet as well as sleep. Um, we capture and grade all of those symptoms as well as the whole history of the condition, and then we begin to identify what syndromes may be at play. And so the different syndromes that I'm talking about are ME/CFS or ME/CFS may be a little bit different than long COVID. We don't have uh, definitive sort of confirmation that they are the same, but certainly there are striking similarities between people who have ME/CFS from other viral illnesses and long COVID, with the hallmark of that ME/CFS syndrome being post-exertional malaise. Then we screen everybody for POTS and orthostatic intolerance. We use a test called the 10-minute stand for that, where we can also use biometric data from wearables, which we'll get into a little bit later. We look at other forms of dysautonomia. Oftentimes people will have a condition called IST or idiopathic sinus tachycardia, or other forms of dysautonomia that don't necessarily follow exacerbation and remission with orthostatic stress or with standing upright, basically. And then we look and screen for symptoms of mast cell activation syndrome or a mast cell activation syndrome-like presentation, because from that, different strategies might flow, as well as different information back to the primary care provider to engage them in some strategies. In the beginning of the program, we use, well, throughout the program, we use wearable tech. So we're talking about like biometric data from watches and things like that to help us to guide the rehab process and to allow for a little bit more information for pacing. And so in the beginning, we do a bit of a setup on that. We get people onto our platform so clinicians can look at their data with them and help them through any of the little sticking points associated with that. Any questions about that assessment process? I don't see any yet, but if you do, feel free to type or speak. So as I was saying, you know, we got a number of questions prior to the webinar on, you know, what are you doing that's helping? What things can I do that will help with long COVID? And because long COVID is such a large and umbrella term, we really have to tailor the strategies and treatments to the individual's syndromes and presentation. There's really no one size fits all. And this is why a number of kind of group-based programs that have a set schedule of content tend to struggle in terms of getting people feeling a lot better, although they can be valuable in terms of understanding pacing and maybe understanding the condition a little bit better. It's harder. This is difficult stuff to action without specific coaching. So we tend to start with the most functionally limiting and changeable problem. And so what do I mean by that? You know, for example, an individual with severe POTS, that particular syndrome can be limiting them functionally to the point where they're not even really experiencing post-exertional malaise because they're not as active as they, you know, the POTS is sort of holding them back. And so when we're thinking about sequencing strategies, we want some early wins. We want to get, you know, low-hanging fruit early, and we want to try and make a material impact on function as early as we can. Oftentimes what we see is that people come into the program and it's unclear to them what is making them worse. Sorry about that. I will speak up, actually. It can be quite unclear what's making them worse because they feel kind of badly a lot of the time. And so by us beginning to control one of the syndromes, we can begin to see what triggers are there and what different things are driving different groups of symptoms. So oftentimes, once we begin to control POTS a little bit better, we start to see the difference between the symptom cluster that's associated with orthostatic intolerance in POTS and the PEM symptoms that the individual might have. And that gives you an opportunity to control them once you understand what the triggers are. Did that help with my volume? Okay. So this slide is a little bit busy. Oh, okay. What is POTS? POTS is postural.
Hold on.
Or is somebody just
Is that
not?
a question? Or I'll just, there we go.
Okay, so we had a question, what is POTS? POTS is postural orthostatic tachycardia syndrome. And it is essentially a form of dysautonomia or a type of syndrome where the autonomic nervous system isn't functioning optimally. And when people stand up or stay upright, their heart rate has to accelerate to try to maintain their blood pressure. Their ability to constrict all of the little vessels throughout their body is reduced. And so when they stand up, blood pools in the lower half of their body and their heart begins to work against that. And so it's characterized by heart rate that increases by 30 beats or more in standing within the first 10 minutes of standing. Now, a lot of people, the reason we have on this slide POTS/OI, which stands for orthostatic intolerance, is that a lot of people won't quite hit that 30 beats per minute threshold, but they have symptoms of orthostatic intolerance and their heart rate response is not normal. It goes up and then they lie down and it comes back down. The reason we cluster those together is that a lot of the strategies that we would use for POTS still apply to those individuals. We might not go down the pharmacology route with primary care, but all of the rehab strategies still apply. And so those two are balled up together. We have a good resource on our website where you can learn a little bit more about POTS. If you go to our resources and in the search bar, you just put POTS, you're going to learn a lot about POTS from that. And in fact, there is a set of instructions for doing a 10-minute stand for yourself as well, where you can actually screen yourself for POTS. So back to this slide, these are the different syndromes that we look at, and underneath them are a variety of common strategies that we might use. In the ME/CFS syndrome or post-exertional malaise syndrome, we're going to be using a lot of pacing. Pacing is a complex intervention that we can talk about a little bit. I've got a slide on that a little bit later, but we're looking at total activity, intensity of activity, using different biometrics and different strategies to try to inform that pacing and make it better. POTS, we use a number of strategies. Most of them come from the Canadian Cardiovascular Society's position statement on POTS. There's an excellent paper that has been put out talking about both non-pharma and pharma interventions for POTS. And it also describes the different subcategories of POTS. Non-POTS dysautonomia, we're using strategies to try and improve parasympathetic drive of the autonomic nervous system. And that particular category is fairly heavy in the biometrics. We use the wearable devices and breathing techniques, things like heart rate variability feedback, and we're looking at a number of things there. Now, in the MCAS group, these are individuals who have kind of allergic symptoms or GI symptoms. We're looking at multiple body systems involved, often with food triggers. In that case, we're using we're engaging our dietitian, who actually sees a lot of our patients, but she would be with this group talking about low histamine diet, anti-inflammatory dietary strategies, as well as discovering the individual's triggers for their MCAS. Most often, we're interfacing with primary care for these individuals and advocating to try some H1 and H2 antihistamines because they seem to help a lot of people in that category. And so you can imagine that if your particular condition, you might have the ME/CFS category and POTS, but none of these other things. Or you might have primarily MCAS and a little bit of POTS. In fact, these problems all kind of overlap with one another. It's not uncommon for us to see a patient that primarily has MCAS syndrome, But when their problem is particularly triggered and we test their POTS, they're positive. But when it's not, they're negative. And so you can see that, they're not completely separate from one another, but separating them from an assessment perspective does help inform what might help the individuals. So patients do typically have more than one syndrome, and probably the two largest and most common ones are that ME/CFS, or post-exertional malaise, as well as POTS. You see there's a question that says, does IST fall into the non-POTS? Yes, it does. Idiopathic sinus tachycardia is not triggered by orthostatic stress, but it is where, the heart rate will become tachycardic at different times throughout the day. So how are individual dietary triggers determined? Is it through an elimination diet or more specific testing? So our dietitian would be an excellent person to answer that question. I think it depends. I think that for some people, an elimination diet will work. For others, they need to seek out some more advanced testing. MCAS is one of those places where it's particularly challenging to get medical support. Specialists that actually work in this area and are really knowledgeable in it can be a challenge. Could thoracic outlet syndrome fall under POTS or non-POTS? Not typically. Thoracic outlet syndrome is a musculoskeletal problem that will create some brachial plexus or nerve symptoms in the upper extremity, but it's a bit of a different pathophysiology to something that is directly impacting the autonomic nervous system. So where does severe fatigue and brain fog fit in? Severe fatigue and brain fog are two of the most common symptoms. They're often symptoms of the ME/CFS cluster. They can also be symptoms of the POTS group and of the MCAS group. So in long COVID, there are a huge number of symptoms, and often those symptoms will apply to more than one syndrome. What's important about them is the behavior of those symptoms. What triggers it? How long after that trigger does it begin and last? And what things can we do that help to control it? That's how we begin to understand the problem and begin to control it as well. And so, the reasons for the fatigue and brain fog may be different in the ME/CFS group than it is in the POTS group, than it is in the MCAS group. But the way that they're felt isn't necessarily. The behavior, the timing, the triggers, those are all the things that set it apart. Oh, thanks, Vi. Yeah, there's a video link to our registered dietitian's approach to long COVID. She did an interview that's on YouTube that you can go and watch. And then underneath these syndromes, there are certain things that we do and that we touch on that help with recovery, no matter what you're recovering from, whether it's a severe musculoskeletal injury, post-viral illness, or something else. We want to make sure that sleep is as good as it can be. We want your circadian biology to be working for us. We want your nutrition to be supporting recovery and ensuring that it's of good quality and is supporting everything that needs to happen for your body. Hydration is particularly important as it pertains to POTS because it is a specific strategy, but it is also important just for recovery. A lot of the population walks around all day a little underhydrated. And so it's important to just touch on that now and again. Stress impacts recovery in a big way. We have occupational therapists and psychologists, or sorry, a psychotherapist who helps us with that. We don't want to be in a state of chronic stress trying to recover from a chronic illness. And also coping. Having long COVID, having chronic illness is exceptionally challenging as it pertains to family, work, loss of roles, and normal life events that you might be dealing with. And so we want to make sure that there's support for individuals in that department, and our occupational therapists and psychotherapists can help with that as well. Regarding hydration, I've been told to keep it low because of a pulmonary hypertension diagnosis.
How are you today? Thank you for
Yeah. Was that aimed at me, that comment there?
Oh, no, I think it was just unmuted.
I see. Yeah, so I mean, if you have a medical condition that requires you not to use the strategy of hydration with electrolytes in pots, then we just need to cross that one off and go with all of the others. We have lots of strategies. People can improve without doing all of them. Okay. Anything before I move on to this next slide? Looks like, oh, hey, no problem. So I'm going to do a little demo. I've touched on the fact that we use wearable technology and biometrics, and I want to show you a little behind the scenes on what we're doing with that and how it provides an advantage. So I'm just going to change my screen share here. So bear with me, because this is usually where things go wrong. All right, here we go. But if you could let me know when.
Yep, I can see your screen.
Okay, so this is demo data. It's just data from me. It's not, we're not going to be picking up any particular insights into the illness from this data. But as a patient, you would have a wearable device on and an app on your phone. That app connects into your wearable device and sends your data to our platform. You don't have to do anything, it just happens in the background. Then your clinician will have set up a number of symptoms that you can track on a daily basis, and you use that app to track those symptoms as well. As your clinician, we can come in here and we can choose sort of a time frame that we want to look at. Let's say the last 4 weeks. I'm going to apply that. And I can look at anything that your wearable likes to report. So if it wants to show me your daytime heart rate, I can look at that versus your activity. And I can trend each of those things. Or maybe I want to look at your minimum heart rate, which is a particular metric of interest to us because it can help assist in pacing. And I can see, so for this particular data set, you can see a net reduction in my minimum heart rate over time. Now, when it comes to tracking the symptoms, these are all being pulled in as well. Of course, they're all turned off at the moment. So if I want to look at fatigue, say, I can turn that on and I can look at how has this resting heart rate correlated with fatigue. Can we get any insights there? Or maybe I want to know how fatigue and activity are related to one another. I can see, relationships there. And so I can see relationships between all sorts of different biometrics as well as symptoms, and begin to use those to help to coach and draw insights from all of that data to help. Of course, this is all useful, much more useful with your context, with, in chatting with with the patient and understanding how they're feeling a little bit more. We can also go into detail on any specific day and see a heart rate tracing. We can see how activity, this green line here, is impacting heart rate. And so we can see when those two things are not also correlating particularly well. And we can ask you to record a quote unquote, what your Apple Watch or Garmin or whatever your choice of device is would call a workout, but may not look much like a workout when you do it. We can get a recording of that and just pull it up and have a look at your heart rate behavior over that period of time. So one of the things that we like to do is to record a 10-minute stand to screen for POTS. So we can have the person do that with their device. They don't have to record their heart rate all the time. We can go in and see over that 10 minutes exactly what happened with the heart rate. It's very, very helpful in that regard. We use some outcome measures that we send from our EMR as well that the clinician will enter in here as well. And we can look at those metrics against people's data as well. We can look at sleep heart rate. Of particular importance for pacing is the sleep low, meaning how low did the heart rate go overnight. And we can look at HRV, which is usually best looked at with larger data sets rather than in a single day. We might look at data average HRV over time. And so if I put a trend line on that, you're going to see a slight upward trend. That makes a lot of sense with our previous downward trend of the minimum heart rate. Those two are inversely related. It should be inversely related. A downward trend of the HRV and an upward trend of resting heart rate spells a bit of trouble and can be a precursor to us saying, you know what, we need to back off a little bit. We're risking a symptom exacerbation or crash.
We have a couple questions, Adam.
Yeah,
So
I
I
figure
think from I think from the previous slide, there was a question from Tanya. Can you not just drink liquids and not electrolytes?
yeah, let me see if I can just get the actual chat. So good hydration does require electrolytes, just if you're always drinking just pure water. Now, a lot of us get plenty of electrolytes from our food, from our diet, but in the case of POTS, the strategy really is to try to kind of unnaturally expand your plasma volume of your blood. And so it does require electrolytes to try and hold that hydration in for as long as you can. But by expanding your blood plasma volume, we're better supporting the maintenance of your blood pressure when you're standing. Any others, Bye?
Yeah, so the other one was, is fatigue self-reported?
Yes, so fatigue, as I was showing it in the platform, yeah, that would be a score each day. You'd be reflecting on your day and just going, you know what, today was a 3, today was a 4. It just gives us a sense of where you're at on that day. And we can track any symptom. So we could be simultaneously tracking headache, fatigue, body aches, different, just about anything under the sun.
Yep. And the other one is it like a blood glucose sensor that goes into your body or worn outwardly?
No, it's a smartwatch. So you might use an Apple Watch, a Garmin, a Fitbit, something of that nature can give us everything that you've seen there. The platform itself is capable of pulling in data from the device that you're talking about, a continuous blood glucose monitor, but we aren't yet using that data.
And then the other one is the symptom entered by the patient?
Yes, it's entered by the patient each day on the app that lives on their phone.
And I think this is a question around the POTS test. The question is, what if you can't stand for 10 minutes without support?
Good question. So, is that, I guess there's some, we're getting into some clinical stuff, but is it due to symptoms of orthostatic intolerance? If so, and heart rate goes up materially when you stand, we kind of have our answer. We certainly want to screen for any other issues. If it's another issue that prevents you from standing, there are other tests that you can seek. You would need a cardiologist to do a tilt table test. And that's a test where you're actually strapped onto a table and it's tilted at different angles, and you're continuously looking at your heart rate and blood pressure.
And then we have Wendy who wants to know a little bit more about what HRV, or can you explain a little bit more about what HRV means?
Yeah, so HRV stands for heart rate variability. It is the variability of the time frame between heartbeats. So when your heart is beating at 60 beats per minute, it's not really beating every second. There are short intervals and long intervals in between, because your heart is constantly responding to all of the different inputs in your body, changes in position, changes in muscle contraction, thoughts, autonomic nervous system inputs, temperature. All of these things are impacting your heart rate. And so what you want is high variability. What that means is that your body is responding to its environment really well and changing to tightly maintain your blood pressure and perfusion of your organs. When heart rate variability goes down, that usually means that the sympathetic nervous system is hyperactive and your heart rate becomes more regular and usually faster at the same time. And so that heart rate variability can be used as long as we have an accurate way, or let's call it reasonably accurate way of measuring it, and we go about it properly, can be used as a leading indicator for pacing. So in the first thing in the morning, if we do a heart rate variability test, or if we happen to have a wearable that gives us our mean overnight heart rate variability, then we can use that number compared to our average, which we're looking at least a 2-week average, and decide, okay, this is a day where I feel, not only do I feel okay, my heart rate variability is at a point where it's indicating that I'm tolerating things well. Maybe I can just push a little bit more. And then there are other times where it's coming down or it's reading quite low, and it just makes you think, it might be smart to pull back a little bit. So it's used for that. We also use it to just demonstrate change in autonomic function over larger amounts of time. What else do we have here?
We have a question on recommendation for a smartwatch, if you have any.
Yeah, I mean, I think most of the popular commercially available smartwatches out there are quite good and have a similar feature set. The two that I tend to steer for people toward are Apple and Garmin. And Garmin can be gotten at a pretty reasonable price point. You don't need to be at the high end of a Garmin to get a good feature set and really good sensors and good data. And so if price is an issue, which for most of us it is, Garmin's a great option. Apple, if you're on the Apple ecosystem, it does a lot. And so it's a nice device to have. I think somebody asked, what happens when your verbal symptoms don't match your watch? Trust the patient, not the data. Data is helpful to inform and to guide and to support. We use that data not just in a predictive way, it can help us to avoid some crashes in that way, but we also use it in a prescriptive way, meaning that at any time you can be using this device as a pacing device. Look at what has my activity been today? Oh, I'm halfway through my budget, and I know that if my symptoms do better if I stay under a certain level, or we might use a maximum heart rate notification where we're trying to pace the intensity. And so you're using it for that. Or we might give you an intervention and say, if you're a little bit further on in your recovery and we're doing some activity, I'm going to call it activity, not exercise, because in long COVID, sometimes the word exercise can be a little bit controversial. We're not sending people to the gym and running on treadmills, but a bit of activity, and we can ask you to do that with really specific parameters because the wearable allows us to do that. And it's really easy for people to follow it. Then not only that, in the platform, we can click it open and see, was that doable? Was that possible for the individual to stay at a specific heart rate for a specific duration and so on.
Question around your current recommendations in terms of getting the current COVID vaccine for those with long COVID or POTS.
Talk to your primary care doctor about that. I'm a physiotherapist, and so I don't dabble in pharmacology. I can give you some evidence. I know that vaccinated individuals are less likely to contract long COVID. I don't know anything useful for people who already have long COVID, if it helps. There have been certainly anecdotal reports of that, but it hasn't really been proven. And I think at this stage, the vaccine decision is one between you, your primary care, and all of your risk factors, and when the last time you were exposed was, and all those things. And so I hesitate to I shouldn't give advice on that because I'm a physiotherapist. I think we had a couple other in there, right?
I think there's one that says if HRV jumps from 12 to 110 back down to 20, what does this mean?
So my comment earlier about HRV needing to be measured in a specific way, this is what that's about. If you look at what your smartwatch will give you for HRV for a day, it'll do exactly that. It's perfectly normal. When you climb the stairs and your heart rate goes up, your HRV is going to go down. And when you've been chilling on the couch for a while and you're down around your resting heart rate, it's going to go up. And then when your teenager stresses you out, it's going to go down further. So what we do is either look at the overnight mean, so the average HRV overnight, or we take it at the same time every day, just upon waking, while rested, and in a full sort of the same way you would take a resting heart rate. And so we're trying to get controlled conditions measurement. This can be confusing in terms of the commercially available platforms out there for HRV. Oftentimes they're reporting like if you just look in Apple Health, it just reports the last reading. I mean, it's meaningless. I had readings today that were in the teens, and I had readings that were over 100, and I'm not sure what I'm supposed to do with that information when it hasn't been taken in an appropriate and usable way. Okay. Does the program also prescribe meds? So we don't prescribe meds because, again, physiotherapists don't dabble in pharma. But what we do is we do interface with people's primary care to try and guide them toward the guidelines for the specific syndromes that we've identified. And so if a person has POTS it's not uncommon that we'll engage their primary care doctor and provide the section of the Canadian Cardiovascular Society guidelines on pharmacology around POTS and hope to give them plenty of support for that. And we work with the Reclaim trial at UHN, and sometimes people are able to access that if they're in Ontario, and that comes with a bit of extra sort of medical support. You're welcome. Are you taking new people, and how do we join? Yes. And we all have information on this last slide for that. So really, it's just a phone call or email, and we'll get you set up. Now, I'm going to just address some of the questions that came in. We might have hit them. Is it OHIP funded? It is not OHIP funded, Lauren, I'm afraid. Physiotherapy in Canada is privately covered unless you have long-term disability that might cover it, or short-term disability that might cover it. But our usual physiotherapy fee guideline applies. And it can be covered by any insurer that would cover rehab physiotherapy. We have leads nicely into the next question. What supports does the program feature? So we have lots of physiotherapists, occupational therapists, dietitian, and psychotherapy. We have one-on-one. Most of the program is one-on-one, but we do have some group formats available as well for peer support and OT support. And we try and engage your primary care physician as well to be a part of that team. Do we work with both adult and pediatric? We do have pediatric clients. We have a good relationship with sick kids, and an open dialogue with them about some of the differences that we see in long COVID in a pediatric population. Is Cornerstone unique to this treatment in Toronto? I think we're unique to our approach, across the country. Haven't seen another program that is using biometrics the same way that we are, and certainly there are programs utilizing the strategies, but with a little bit less data. You don't need a doctor's referral. There are some public group-based programs in Ontario that have mostly stopped taking new patients recently, and I know that in Alberta, all of the clinics were defunded and have closed down as well, which is awful. And we're hoping to be able to someday be a solution there, but for the moment, we're in the sort of private pay sphere. Vi, I'm going to leave the questions for you at the end of the slide, okay?
Okay.
Will brain fog, fatigue, and muscle weakness ever get better? That's the golden question, right? That's the question everybody wants to know when they come in. I will tell you that we are seeing people who are able to follow the advice and action it improve substantially. It takes time. It's called long COVID for a reason. People engage with us for an average of a year, but they do get their condition under control. And long COVID is an episodic illness. And so the amount of control you have to exert to keep it that way varies over time. But our goal is to teach you how to put your body in a place where recovery is possible and to keep it there over time. And then we begin to see the recovery take place. I don't think, or, we don't know yet, but I would hesitate to take credit for anyone's recovery. We take credit for teaching people to manage the condition as well as they can, put their body in a place where it can do its thing and recover. A lot about this condition is unknown in terms of prognosis, its episodic nature, and recovery versus management. But, we're learning more every day. And I think that we're participating in research and hoping to be able to answer those questions a little bit more clearly down the road. Bye.
Yeah. So we have a question that says, is the program fully in person?
I can't believe I haven't covered that. The program is fully telehealth. So
Virtual.
we have the platform to be able to share data with you and interface with you by telehealth. And yeah, it's even for people who are local to our clinics, there's not a lot of upside to them coming in and doing things face to face. And so we do the whole program through telehealth. And that's for that reason, it is open to anyone in Alberta, BC, and Ontario.
Do you treat patients with these symptoms regardless of whether their trigger was infection or vaccine?
Yes, we do have other individuals in the program who their long COVID was triggered by their vaccine.
The last long COVID rehab program I was in before it shut down had a super helpful virtual group weekly activity class. Does this program have something like that?
We do have a group format that runs maybe 4 times a year where you can sign up and there's some education, some facilitation, but there's also some peer sharing and support that goes on.
And then what is the cost? It's, yeah.
So the
Yeah.
cost is our usual and MSK fees. You can see those on the website. The assessment's $132, follow-ups are 88. The assessment's an hour, follow-ups are 30 minutes. And people are not seeing, this isn't like, you've dislocated your shoulder and you need to see a physio regularly. People at the very beginning are seen weekly until we can get some of that low-hanging fruit and get things under control, after which it's every 2 weeks. So, it's a little more spread out than you might be used to with physiotherapy if you've had a previous experience. Anything else, Bye?
Yeah. Do you know of groups that provide similar services in the province of Quebec?
I don't, but I do get that question a lot.
Mhm.
Our intention is to expand to other provinces. Right now, we've just recently expanded to Alberta and BC. Because of the way that rehab providers are licensed, they're licensed provincially. Whenever we expand, we have to go and find physiotherapists. We're training them from scratch and bringing them through our course. Whenever we do anything at Cornerstone, we do it with a lot of training and mentorship and support. And so for us to launch in a new province, it means we started work quite a long time ago to get a team that is ready and has experience.
Can you tell if it's vaccine caused or not?
I can't know. The reason I know that is just because of my affiliation with University Health Network. There was a small arm of the CanCove study that looked at individuals who had contracted long COVID and after advanced antibody testing had shown that they had never contracted the virus.
Um, Is there a different process to sign up for group versus individual?
Yeah, so the groups are announced a little bit before, a few weeks before they begin running to everybody who is in the program. So most of the people in the groups are a part of our individual patients as well. We've looked at changing that. We may open the groups up for people to be able to access them without already being an individual patient.
Do we assess for any underlying conditions like hyperflexibility, EDS?
Yeah. There are a number of associated conditions. EDS, Ehlers-Danlos syndrome is EDS for those who maybe don't know that. Fibromyalgia. So we are whenever you're dealing in long COVID, because the definition of long COVID again is super broad. If we look at the World Health Organization definition, it's symptoms after acute COVID infection that last, 3 months or more, and it's very, very broad. And so we have to be aware of individuals who might have something else going on a lot of the time. And so we're in the unique position to have a large cohort of individuals to have experience and have spent time with a large cohort of individuals with long COVID. And so when something's not fitting, it's a little bit, it tends to stick out.
Um, would you be willing to take a patient on from Quebec as part of the program?
We can't until we have rehab providers that are licensed in the province of Quebec.
Have we reviewed any medical studies which show which exercises are most effective?
So that's a tricky question because it really depends on the patient and the syndrome. I wouldn't, if you have long COVID, you need to go into exercise with caution. If you're an individual who experiences post-exertional malaise, meaning a crash or a worsening of symptoms that takes place after activity, with significant caution. And so whenever we add activity or exercise, we do it conservatively, and then we move in small increments. And that's what the wearable tech really allows us to do, is to be able to move people in small increments and monitor symptoms and biometrics to ensure that it's being well tolerated. And so, the path to improving from long COVID is to stay inside what some people call your energy envelope or your spoons or what have you, whatever your particular analogy is, and to operate at the highest level of function that you can without worsening your condition or experiencing symptom exacerbation.
Best way to sign up.
Last slide. So there's an email, there's a phone number. We'll give you lots of options on that. I'm going
And
to, sorry.
go ahead. Go ahead, Adam. Go
So I'm
ahead.
going to jump into pacing because pacing is of incredible importance with this condition. The term pacing sounds simple. Like when I learned it originally as a rehab provider, I thought, oh yeah, pacing, like pace yourself. I get it. No, it's exceptionally complex. And when you're the individual with the syndrome, it can be hard to sort of see the forest for the trees because there's so many things impacting how you feel. So we have to consider activity, cognition, stress, emotion, and environmental factors when it comes to pacing. You have to consider the total volume, the intensity, and not just today, but the recent history. So maybe 5 days of history in terms of the amount of activity I've done, or cognition or stress, and so on. It takes place at different levels. So if we're thinking about pacing, maybe it's a Monday and I'm planning my week. I need to think about it at the task level, meaning I need to break things up, I need to reduce intensity, I need to take breaks. At the daily level, so I might only put depending on where I'm at in my condition, I might only put like one obligation in each day rather than stacking them in my calendar. And then at the weekly level, I need to put things across my week in a way such that I'm going to be able to do the things that I absolutely need to get done. It's important though to impress upon people, both the patient and maybe other individuals supporting them or employers, that pacing, it's not about doing less. In fact, it's about doing more. It's about being able to operate at the highest level of function possible without worsening your condition. And so for pacing well, more is getting done. That multitude of factors that you have to consider all the time makes it difficult. And having that third party removed set of eyes that can help you through both your symptoms, your priorities in terms of pacing, and coach you through it is really helpful. It's often really I'm sure if individuals have long COVID, I'm not telling them anything they don't know, but it's exhausting to have to explain your needs to others, to constantly try and explain how pacing helps you. And having data to show the value of it and to see how you can show how you can get more done as long as you make these adjustments is really important. Anything on pacing there? Do you want to leave the rest of the questions in the chat to the end?
Yeah, let's do
Okay.
that.
What therapies are you offering that are helping your patients? Again, I think we've kind of touched on this, that there's really no single recipe here. Strategies are employed that have to be matched to the syndromes and the symptoms. And they have to be consistently adjusted due to the episodic nature of the problem, as well as the changing needs in the person's life. Clinical studies, we are early days on rehab studies in long COVID. Most of the research, understandably, is going toward pharma interventions, is going toward biomarkers and epidemiology, prognostic studies, things of that nature. We have and continue to lean on a research body from POTS, from MECFS, from MCAS. These conditions have been around for a longer period of time, so there's a little bit more research consensus on them. And then we as a group are involved in ongoing research. We're members of Long COVID Web. We're members of the Rehabilitation Science Research Network for COVID, and we're actively engaged in research. In fact, the platform that we built for data collection will be a valuable tool for research. That is not suggesting that your data is being used for research, but rather that we can use that platform in studies as a separate instance that will contribute to the body of knowledge. Post-exertional malaise and exercise. This was a question that was sent in. It's a super complex topic. It's fascinating though. The objective when it comes to post-exertional malaise is to avoid it and to slowly increase function. We use pacing to achieve sort of a basic level of activity and activities of daily living. So that's like cooking, cleaning, moving about the house. First, before we introduce any structured activity or intentional exercise. Like I mentioned before, it requires a very conservative start. You have to progress in tiny increments and monitor symptoms and biometrics in order to avoid crashes. You have to allow for the episodic nature of the condition, meaning that what you did last Tuesday will not necessarily closely inform what you can do this Tuesday. We have to, in order to see changes over time, we have to zoom out further than that and look at the data. Now, one of the fascinating things about MECFS and people with long COVID who show that syndrome is that they have a dynamic anaerobic threshold. So what that means essentially is that their ability to produce produce energy in the form of ATP using their aerobic energy system on some days is lower when they're experiencing post-exertional malaise, and on other days it's a little bit bigger. And so what that means from a practical standpoint is that if you are in a crash, the best way out of it is fully rest. because your ability to produce energy using your aerobic system is impaired. And even if you shut down your activity a bit because you say, you know what, I'm not feeling well today, I'm going to shut it down a little, you still might be overshooting that new lowered anaerobic threshold. And so we usually advise that if people are heading into a crash, that the quickest way out is total shutdown until they feel better. Biometrics are coming online, symptoms are coming online, and then we can re-engage. Yeah, so clinically, it appears that individuals who respect their symptoms and consistently make an effort to operate at the functional level they can tolerate without experiencing PEM experience the best recovery over time. Yeah, and again, that second set of eyes on your symptoms and data is very useful. Okay. Questions from the chat.
Yeah. So one of them was, how do you deal with massive chronic pain or overall body pain?
It's challenging for sure. We might need to engage more than just our team. We might need to engage primary care to try and help with that. We do find that in the case of long COVID that while not all the symptoms move together in time, the same strategies cause them to move in the same direction. So when we begin to get the whole syndrome under control, we start to see a reduction in most or not all symptoms. They might just go on different timelines. And, the chronic body aches sometimes come together quite quickly, and other times it's a more difficult challenge. Certainly people tackle them with other symptomatic management strategies that you might see in an MSK clinic. Some patients undergo acupuncture and things of that nature that try and help with their symptoms. But I can't emphasize enough, like doing our best to manage the overall condition is probably the best and most powerful strategy.
A question from Amarjeet, why couldn't you use patients' data for research studies in collaboration when Long COVID Web and Dr. Chung's ongoing research initiatives, especially if it was done anonymously?
So we have we have the ability when people onboard to the platform to opt in to allowing us to use anonymized data for research. That research is really preliminary research. So what we've done here at Cornerstone is we've identified a number of patterns and we've handed those up to researchers in academia for more rigorous investigation. Because we're a private organization and individuals need to have resources in order to participate, that acts as an inclusion criteria that makes, that you wouldn't find it in the New England Journal of Medicine. Let's put it that way. So, we can see patterns, we can see insights, and then we can prove that with data that can be used to help career researchers to secure funding for larger studies that are more inclusive to everybody.
And I think we have a last question that says, is there a wait list to enter the program?
There's a short wait list now, but we also have a cohort of therapists that are taking on more capacity. So we expect that wait list to come down. That wait list exists in Ontario. In Alberta and BC, we're not on a wait list at the moment.
Yep, I think that was the end of questions, Adam. Yeah, well, I think we'll wrap up here. So thanks everyone for joining the call today. And if you want to reach out to us Feel free to email us at telehealth@cornerstonephysio.com and go through our website. We have a lot of resources and some great articles that are written by our team. And have a great rest of your night.
Thank you, everybody.
Bye, everybody.
Thank you.
Bye.